Hi everyone, my name is Talk Munoz and I am a postdoc at King's College London, and today I'm going to present our work on efficient 3D Cartesian aortic MR angiography in 3 minutes. MR angiography is a well-established technique for the assessment of the thoracic vasculature in a variety of aortic diseases. Both contrast-enhanced and non-contrast-enhanced approaches have been used to visualize the aortic anatomy, using imaging approaches that are typically based on balanced SSFP sequences with T2 preparation and diaphragmatic navigator gating. Although these sequences have been around for over a decade, long and unpredictable scan times have limited their widespread adoption in the clinical routine. Furthermore, diaphragmatic navigation assumes that the respiratory motion of the aorta is rigid, but we know that the aorta moves in a complex, non-rigid fashion during free breathing, so this approach might produce suboptimal image quality. Self-navigation and respiratory-resolved reconstruction approaches have recently enabled aortic MRA from scans of around 6 minutes with very promising results. However, these approaches use non-Cartesian trajectories, which together with the respiratory-resolved approach can result in very long and clinically unfeasible reconstruction times. The aim of this work was to further accelerate Cartesian MR angiography to achieve a short scan time of approximately 3 minutes. In order to do this, we use a variable density 3D Cartesian trajectory with a spiral profile order, which enables undersample acquisitions. We integrated 2D image navigators to track the superior, inferior, and right-left motion of the aortic arch in a heartbeat-to-heartbeat basis and enable 100% scan efficiency and a predictable scan time. Finally, we incorporated fat saturation and T2 preparation modules to improve the contrast between blood pool and surrounding tissue. Our reconstruction framework is as follows. In the first step, superior-inferior motion estimated from the image navigators is used to group the 3D data in a number of respiratory bins. In each bin, superior, inferior, and right-left motion are used to correct for intra-bin translational motion. Once the data has been binned and translationally corrected, images are reconstructed at each respiratory position and used to estimate 3D non-rigid deformation fields throughout the field of view. Finally, the bit-to-bit and bin-to-bin motion information are incorporated into a motion-compensated iterative sense reconstruction to produce one motion-corrected image that includes all the acquired data. In order to make our method available for testing and integration into the clinical practice, we implemented this whole pipeline in the scanner software. In order to test our approach, we performed a proof-of-concept study in 10 subjects. We acquired images with our technique using a resolution of 1.6 mm isotropic and threefold undersampling to achieve the acquisition time we aimed for. Some of these patients also underwent conventional diaphragmatic navigator-gated contrast-enhanced MRA as part of their standard of care. In such cases, these images served as a gold standard reference. Moving to the results, we can see here coronal and sagittal views of uncorrected images for 2 subjects, where blurring and aliasing due to respiratory motion are present. When correcting for rigid respiratory motion, such artifacts are reduced. However, as we know, the motion is really non-rigid, so there is residual blurring in these images. Finally, when applying the whole non-rigid motion compensation method, further improvements can be observed throughout the field of view, including in the coronary arteries and the liver vasculature as indicated by the red arrows. When comparing to the conventional method, we could observe that our proposed approach produces very good image quality compared to the standard approach, in a scan that required under half of the time in this case. We can see in the reformatings in different planes that our method offers good image quality throughout the field of view and enables a very comparable depiction of the aortic arch, the descending aorta, and the left ventricular outflow tract as we can observe in the images below. Finally, our method produces consistent good image quality across patients with a range of anatomies and heart rate. In these examples, we can see cases with heart rates ranging from 66 to 78 beats per minute. And in all cases, we see a very good depiction of the thoracic aorta from a scan with a consistently short acquisition of under 3 minutes. So to summarize, we have introduced here a framework for efficient aortic MR angiography in approximately 3 minutes. We use a Cartesian acquisition with 100% scan efficiency, together with a motion-compensated reconstruction approach that enables reduced and predictable scan time. And we implemented a full inline reconstruction that allows for fast clinical testing and adoption. Our results are very promising, showing high-quality depiction of the thoracic aorta. However, validation of our technique in a larger cohort of patients is now required. Thanks a lot for your attention and have a lovely day.